This is Namitha Seth Mota for NEJM Catalyst. Today, I am speaking with Dr. Sarah Flynn, Assistant Clinical Professor of Medicine in the Division of Hospital Medicine at University of California, San Francisco. Dr. Flynn and her team is focused on an important topic we can all relate to: earning and building the trust of our patients through demonstrated, and actual, of course, teamwork. During our conversation today, Dr. Flynn and I will discuss the work that she is co-leading on the inpatient floors at UCSF around teamwork by improving nurse MD communication. And what I really respect about these efforts is that based on their recent research, they have actually suggested stopping some expectations around certain rounding norms. Most literature usually suggests that we start doing more and more in the same amount of time. UCSF is doing things differently. Sarah, thank you for speaking with NEJM Catalyst today.
Thank you so much for having me today, Namitha.
Let's start with some level setting. Tell us a little bit about your initiatives related to bedside rounding. Start by sharing why you focused on this to begin with and what you've learned.
Yeah, so to give some context to this work, almost 2.5 years ago, my colleague, Dr. Esther Shung, and I were tasked with working to broadly improve physician-nurse communication, specifically among our hospital medicine colleagues. And this was identified as a quality improvement priority amongst faculty in our division, as well as our nursing colleagues and members of our patient and family advisory council. Our early discovery work really focused on identifying communication challenges amongst physicians and nurses, and then working to design and implement initiatives to respond to and to address these identified pain points. And I will name that we had strong stakeholder engagement in these efforts with dedicated nursing and physician champions. And we had three main interventions that we introduced on our hospital medicine direct care service, or our attending only clinical service. These interventions focused on ensuring proactive care plan communication, facilitating bedside co-rounding with nurses, and developing guidelines to improve the way that we communicate through our secure messaging systems. Without going into too many specifics, we used survey data completed by both physicians and nurses to evaluate the interventions, improving care plan communication and bedside co-rounding. And after the introduction of the interventions, we saw very high rates of proactive care plan communication, with hospitalists reporting that they were communicating an anticipated care plan to the nurse for about 90% of their patients. In comparison, hospitalists reported that they were inviting nurses to join bedside rounds for only about 30% of their patients. And when invited, nurses reported they only joined about 50% of time. Qualitative survey comments, as well as some additional data collection efforts, highlighted some ongoing barriers to physicians and nurses bedside rounding together. These barriers included, I think, first, competing care team priorities. So physician rounding typically happens in the morning to help guide clinical decision making. But mornings are especially busy for our nursing colleagues, particularly during med pass times. And we heard from nurses that sometimes they would feel stuck in a patient's room, especially during longer or serious conversations between the patient and the physician, and that the nurses were unable to attend to more urgent needs of their other patients. Another barrier cited very frequently was difficulty with coordination. So at our institution, we do not have geographical co-localization of patients. And as hospitalists, we care for patients throughout the entire hospital building. So when you're on the direct care service, it's not uncommon to be taking care of 10 patients who are spread throughout various floors and units of the hospital, each with a different assigned nurse, really making the coordination of bedside co-rounding logistically very challenging as well as time consuming. Lastly, I think universal bedside co-rounding, so co-rounding for every patient, was felt to be of overall low utility. From a nursing perspective, we heard that they felt it was not a good use of their time and not respecting the other demands and responsibilities of their job, especially when they're needing to respond to other patient care tasks. So, given these challenges expressed by physicians and nurses, we also wanted to learn more about patient experiences with bedside co-rounding. And we conducted semi-structured interviews with patients who were hospitalized on the medicine service to learn more about how bedside co-rounding impacts patient experience. And in our small study, patients reported high satisfaction with care team communication and with perceived teamwork, independent of bedside co-rounding. The qualitative data that we collected through this study really highlighted that patients valued knowing that their physician and nurse were communicating, but didn't need to see them together in the room at the same time to perceive high levels of teamwork. And so this reinforced the importance of ensuring bidirectional communication between physicians and nurses. And for us and our team, has led to deprioritizing our intervention, which facilitated universal bedside co-rounding, and instead have reprioritized our intervention, encouraging proactive care plan communication every day for every patient.
That is really fascinating as a hospitalist who practices in a hospital where we are, at least on the medicine service, still encouraged to round with the nurse every day, in person on the floor and by the bedside when we can. I do think that there are scenarios where bedside rounding makes sense. And so, how did you all think about specific situations when it's worth the effort, and have those been formalized?
We absolutely agree, Namitha. Based on feedback through this work from physicians and nurses, we identified certain clinical scenarios where care team members felt like having both the physician and the nurse in the room at the same time was of high value and worth navigating the challenges associated with coordinating bedside co-rounding. So the first is patients with high clinical acuity. So if you're worried about a patient clinically decompensating or needing an escalation in their level of care, for example, from TCU to ICU, having the physician and the nurse both in the room together is important to make sure that they're seeing the same things, that they're sharing the same level of concern and aligned on the plan for anticipated diagnostic and therapeutic interventions. The next scenario is patients with behavioral challenges. And this is really broadly defined and can include patients with active psychiatric comorbidities, patients with significant delirium, or if there are concerns for patient or staff safety. And then the last clinical scenario identified by our physicians and nurses is really patients with difficult medication titration plans. And within this category, specifically with weaning or changing pain medication regimens, we heard from our nursing colleagues that having the in-person alignment between the patient, physician, and nurse on the planned medication changes for the day and visibly showing the physician and nurse our united team is incredibly valuable. So, although we've deprioritized bedside co-rounding for all patients, we have explicitly emphasized the benefits of bedside co-rounding for these specific patient scenarios. And again, this was based on the direct input from our hospital medicine physicians and our nursing colleagues. And I think it's really important to name if there are other scenarios where a provider, whether that be a physician or a nurse, feel that bedside co-rounding would be beneficial for a patient, we encourage them to voice that. And for both the physician and nurse to then work collaboratively to facilitate bedside co-rounding for that patient.
Do you track in any formal way how successful you've been with success rates for bedside rounding for patients who meet these criteria or one of the three different criteria versus not?
Yeah, Namita, I wish we had better metrics and better data to be able to do that. Unfortunately, limited in what we have available to track that. We have been reliant mostly on surveys that are sent to physicians twice a week when they're on service, as well as surveys from nurses. And I think we can all recognize some of the limitations of using data that is, survey based and with the limitations of our system, it was the best that we've had. So I would love to be able to collect more robust data about this, but in the meantime have really relied on surveys, which include quantitative questions that have some Likert scales, as well as opportunities for open-ended responses to be able to collect some of that qualitative data. I will name, we've also had various groups, particularly of medical students who are interested in looking at this more deeply and have been able to do some kind of informal auditing, additional conversations and focus groups, et cetera. But I do wish we had better ways to track this. And in the meantime, are reliant on the survey data that we do have.
Some data is better than no data, and I
Exactly.
appreciate the ongoing effort to be intentional about what works and what doesn't. Let me change focus slightly. We've been talking about improving communication. That's one of the objectives, obviously, of rounding and working directly with your care team on a daily basis. It also is a way to build team amongst providers and the larger care team. If we're saying that bedside rounding is going to be deprioritized, uh, how do we hardwire teamwork if we're not engaging with what has been a traditional rounding model and let's say relying more on secure messaging as many hospitals now are? What happens to building team?
Yeah, I think that's a great question. And, one way that we are working to do this is through our intervention, encouraging proactive care plan communication, which we have named Touch Base by 12. And so this intervention includes the expectation that physicians communicate an anticipated care plan to their patient's bedside nurse by noon at the latest. And we're not prescriptive about how this communication happens, whether it's via secure messaging, as you mentioned, or over the phone or in person, just that this communication happens every day for every patient. And importantly, this ensures bidirectional communication between the physician and the nurse. And having the physician proactively start that discussion and invite ongoing communication and dialogue from the nurse can reduce a sense of perceived hierarchy between physicians and nurses, really showing respect for our nursing colleagues' input as valued members of the care team. We've also encouraged our hospitalists and nurses to incorporate this into their direct communication with patients. So, using colleagues' names and sharing what they've already communicated about. So, for example, when I round on a patient and I'm setting the agenda for our visit, starting the visit by saying something like, when I spoke to your nurse, Kurt, this morning, he
Mm.
shared you had concerns about making your oncology appointment last week. Or I'll end the visit with a patient by saying, your nurse, Monica, and I are already connecting this morning, And she is going to keep me updated throughout the day about how your nausea is doing on the new medications we started today. So, with our touch base by 12 intervention, we are encouraging bidirectional communication to actively foster teamwork and not just at one touch point, like during bedside co-rounding, but really throughout the day, especially as care plans evolve or there are clinical changes with patients.
What I really appreciate what you're saying, Sarah, is you're actually not only touching base by 12, but taking it a step farther and communicating to the patient that you have touched base. So a lot of times patients and families don't necessarily, not through any fault of their own, realize the many communications that happen not only between nurses and physicians, but between all members of the care team, because we haven't necessarily gone back into the room and structured the conversation as such. So these scripts that you're saying that you start with, which is, I spoke to your nurse Maria this morning, or Kurt and I talked about, is actually in real time demonstrating to the patient that you are in fact outside of the room coordinating and working as a team, which I think is related but distinct and in a positive addition to the touching base by 12, because the patient then is able to build and have the trust in the care team that we keep talking about. Because what I find when I'm in the room is I go in and all the nurses and the doctors and the residents' name may be written on a whiteboard,
Mhm.
don't always communicate with effectiveness that we are actually working as a team. So your point about how you communicate with the patient is also a valuable one.
Absolutely. And I think, it goes back to some of the work that we did investigating and looking at patient experiences with teamwork and with, communication satisfaction. And it is being very explicit that that communication with so many different care team members is happening behind the scenes, and giving that reassurance to patients and to their family members that we are united and we are aligned in caring for them during their hospitalization is really essential to this work.
And I would put a plug in for doing that also with the consultants. So
Absolutely.
whether it's the surgeons or the cardiologists or the nephrologists,
Yep.
it goes beyond that, because how many times do we walk into a room and the patient is the person who's stringing all the work streams or all the different care plans together, which, nobody likes. So
That
we can
resonates. Yes.
we can put them on the list for the next frontier, which gets to my next question, which is, how are you and your teams thinking about spread and scale across the entire institution? And what are some of the biggest challenges that you are facing as you're promoting these very specific types of rounding to improve outcomes and build team?
Yeah. So our intervention encouraging proactive care plan communication for every patient every day has been very well received by hospitalists and our nursing colleagues because it ensures bidirectional communication and fosters teamwork. And we've seen high rates of uptake and, really based on survey data, improved satisfaction with communication reported by both physicians and nurses. And so we are using the quantitative and qualitative data we've collected to support the expansion of these efforts. And this past academic year, we've expanded the intervention, encouraging proactive care plan communication, specifically to our internal medicine residents, with similarly positive results. And we are actively working with our health system leaders to expand these efforts to other non-medicine clinical services. An important part of this expansion is ensuring that we have strong champions of the work to encourage service-specific buy-in prior to implementation. And as you alluded to earlier, as we think about implementing this across our system, we're also exploring how we can better monitor its implementation uptake and really measure its associated impacts on a larger scale. I think, the other thing that I'll name that our group is actively working on is really thinking about how we can use technology for communication, and how we can optimize that technology to facilitate bidirectional communication and improve teamwork. And so that is an ongoing effort in addition to the work that we've done when we think about care plan communication.
Excellent. I have many questions, but as is always the case with a really good conversation, we run out of time before we can get to all the questions that I have. Dr. Flynn, thank you so much for your time today, and we look forward to hearing about how you continue to have impact on the floors and system wide at UCSF. Thanks for joining us today.
Well, Namitha, thank you. It has really been a privilege talking with you today. And I agree, we could have talked for so much longer, but really grateful with the opportunity to get to share just some of this work with you and your audience. And I do want to name that this work has truly been a team effort. And while I am representing our interdisciplinary team here, I do want to recognize my hospital medicine colleagues in this work, Dr. Esther Shung and Dr. Molly Cantor, our nursing champions, Kurt Refuerzo, Monica Riley, Ahmed Terry, and Mila Umali, as well as medical students, Claire Howlett and Zainab Apalera, who have all been instrumental in moving this work forward. So, on behalf of our team, thank you to you and your team for having me today and for highlighting this work.
It does, in fact, take a team. Thank you so much, Sarah.
Thank you.